Welcome to our comprehensive guide on the principles of periodontal instrumentation. Effective instrumentation is essential for successful periodontal treatment and is governed by several universal principles. These include accessibility, visibility, illumination, activation, retraction, and maintaining sharp, clean instruments. Throughout this video, we'll explore each principle in detail, providing practical examples and visual demonstrations to help you master the art of periodontal instrumentation. Whether you're a student, clinician, or simply interested in dental procedures, understanding these fundamentals will enhance your skills and ensure optimal patient outcomes. Let's begin by visualizing the core principles of periodontal instrumentation. These principles are accessibility, visibility, illumination, activation, retraction, instrument condition, sharpness, stabilization, and maintaining a clean field. Each principle plays a vital role in ensuring thorough and safe instrumentation. For example, accessibility allows the clinician to reach all areas of the mouth, while proper illumination and visibility help identify calculus and plaque. Retraction techniques improve access and protect tissues, and sharp instruments make procedures more efficient and comfortable for both patient and clinician. Maintaining a clean field is crucial for infection control and clear vision during treatment. Accessibility is the foundation of effective periodontal instrumentation. The position of both the patient and the operator is critical for maximizing accessibility to the treatment area. Poor accessibility can hinder thorough instrumentation, tire the clinician prematurely, and reduce effectiveness. The patient should be positioned in a supine posture, with the mouth close to the clinician's resting elbow. The clinician's forearms should be parallel to the floor, weight evenly balanced, thighs parallel, and hips at a 90-degree angle. Proper seat height ensures the clinician's heels touch the floor, creating stability and comfort during procedures. The neutral seated position for the clinician is essential for both comfort and effectiveness. Forearms should be parallel to the floor, weight evenly balanced, thighs parallel, and hips at a 90-degree angle. The seat height must be low enough for the heels to rest on the floor. When working from clock positions 9 to 12, the clinician should spread their feet apart, forming a tripod with the chair base for stability. Avoid positioning legs under the back of the patient's chair. Keeping the back straight and head erect helps maintain posture and reduces strain during long procedures. Maintaining a neutral neck position is crucial for preventing musculoskeletal issues. The clinician's head should be tilted between 0 and 15 degrees, with the line from the eyes to the treatment area as vertical as possible. Avoid tipping the head too far forward or to one side, as this can lead to discomfort and long-term injury. Proper neck alignment ensures the clinician can focus on the treatment area without unnecessary strain, promoting both accuracy and endurance during procedures. The clinician should lean forward slightly from the waist or hips, maintaining trunk flexion between 0 and 20 degrees. Overflexion of the spine, resulting in a curved back, should be avoided. This neutral back position helps distribute weight evenly and prevents fatigue or injury. By keeping the spine aligned and avoiding excessive bending, clinicians can work efficiently and comfortably throughout lengthy procedures. Shoulders should be kept in a horizontal line, with weight evenly balanced when seated. Avoid lifting shoulders toward the ears or hunching them forward, as these positions can cause tension and discomfort. Sitting with weight on one hip should also be avoided. Maintaining a neutral shoulder position supports proper posture and reduces the risk of musculoskeletal problems, ensuring the clinician can perform procedures with precision and ease. Proper positioning of the patient's head is essential for accessibility and comfort. The foremost part of the patient's head should be even with the upper edge of the headrest. For mandibular areas, the chin should be down, while for maxillary areas, the chin should be up. Adjusting the headrest ensures the neck and head are aligned with the torso, allowing the clinician to see and reach the patient's mouth comfortably. These positions facilitate optimal access to different treatment areas. The clinician's upper arms should hang parallel to the long axis of the torso, be at waist level, and held slightly away from the body. The arms should not be more than 20 degrees away from the body or above waist level. This neutral upper arm position helps maintain comfort and control during instrumentation, preventing fatigue and ensuring precise movements. Proper forearm and wrist alignment is vital for effective instrumentation. The forearms should be parallel to the floor, and the wrist should be aligned with the forearm. Avoid bending the wrist up or down, and ensure the thumb side of the palm is not turned excessively. This alignment allows for controlled, precise movements and reduces the risk of repetitive strain injuries. The clinician's hand and fingers should be positioned so that the little finger is on the side of the palm and the wrist is aligned with the forearm. Avoid bending the hand or wrist up or down and keep the thumb side of the palm parallel to the floor. Proper hand and finger positioning ensures stability and control during instrumentation, minimizing the risk of injury and maximizing effectiveness. The supine patient position is recommended for most periodontal procedures. In this position, the patient lies flat on their back, with the head aligned with the end of the headrest. This allows the clinician to access the oral cavity easily and comfortably. Proper patient positioning is essential for both accessibility and patient comfort, facilitating thorough instrumentation. Clinical positions vary for right and left-handed clinicians. For right-handed clinicians, the 7 o'clock position is to the front of the patient's head, 9 o'clock is to the side, 10 to 11 o'clock is to the back, and 12 o'clock is directly behind. Left-handed clinicians use similar positions but adjusted for their dominant hand. These positions ensure maximal accessibility and comfort during procedures, allowing the clinician to reach all areas of the mouth efficiently. If the headrest is adjustable, it should be raised or lowered so that the patient's neck and head are aligned with the torso. The top of the patient's head must be even with the end of the headrest to ensure comfortable access to the oral cavity. Proper headrest adjustment is a simple yet crucial step in preparing for periodontal instrumentation. Visibility, illumination, and retraction are key components of effective periodontal instrumentation. Direct vision with direct illumination from the dental light is most desirable. When direct vision is not possible, indirect vision can be achieved using a mouth mirror to reflect light where needed. Indirect vision and illumination are often used simultaneously, enhancing the clinician's ability to see and treat all surfaces. Dental mirrors come in various types: front surface, concave, and plane. Front surface mirrors produce a clean, clear image with no distortion but are easily scratched. Concave mirrors magnify the image but can cause distortion. Plane mirrors produce a double image, which can be distracting. Choosing the appropriate mirror type is important for accurate visualization during periodontal procedures. The dental mirror is a versatile hand instrument used for indirect vision, retraction, indirect illumination, and transillumination. Transillumination involves reflecting light through the tooth surface, making the tooth appear to glow. This technique is effective with anterior teeth, which are thin enough to allow light to pass through. Proper use of the dental mirror enhances visibility and access during periodontal instrumentation. Dental light positioning varies for mandibular and maxillary teeth. For mandibular teeth, position the light directly above the patient's head, shining directly down into the mouth. For maxillary teeth, place the light above the patient's chest and tilt it to shine into the mouth at an angle. Proper light positioning ensures optimal illumination and visibility during treatment. Retraction provides visibility, accessibility, and illumination. Effective methods include using the mirror to deflect the cheek, fingers of the non-operating hand to retract lips, and the mirror alone to retract lips and cheek. The mirror can also be used to retract the tongue. Combining these methods ensures optimal access and protects the angles of the mouth from irritation. Before any instrumentation, all instruments must be inspected to ensure they are clean, sterile, and in good condition. The working ends of pointed or bladed instruments must be sharp for effective calculus removal. Sharp instruments improve stroke control, reduce the number of strokes, increase patient comfort, and reduce clinician fatigue. Dull instruments can lead to incomplete calculus removal and unnecessary trauma. Maintaining a clean operative field is essential for effective instrumentation. Saliva, blood, and debris can obscure visibility and hamper procedures. Adequate suction, achieved with a saliva ejector or aspirator, is crucial. Blood and debris can be removed by suction, wiping, or blowing with gauze squares. The operative field should be flushed occasionally with water, and compressed air and gauze squares can facilitate visual inspection of tooth surfaces during instrumentation. Stability of the instrument in the hand is a prerequisite for controlled instrumentation. Stability and control are essential for effective procedures and to avoid injury. Two factors provide stability: instrument grasp and finger rest. A proper grasp allows precise control of movements, while a good finger rest stabilizes the hand and instrument, preventing injury and laceration of tissues. The most effective and stable grasp for periodontal instruments is the modified pen grasp, which allows precise control and facilitates good tactile conduction. The palm and thumb grasp is useful for stabilizing instruments during sharpening and for manipulating air and water syringes. Choosing the right grasp enhances control and efficiency during periodontal procedures. Finger rests stabilize the hand and instrument by providing a firm fulcrum. The ring finger is preferred for the finger rest, and maximal control is achieved when the middle finger is kept between the instrument shank and the fourth finger. Finger rests may be intraoral or extraoral, each offering unique advantages for accessing different areas of the mouth. Correct finger placement is essential for effective instrumentation. The thumb and index finger pads rest opposite each other at or near the junction of the handle and shank, forming a C shape. The middle finger rests lightly on the instrument shank, guiding the working end and feeling vibrations. The ring finger balances firmly on the tooth, supporting the hand and instrument. The little finger is relaxed and has no function. Intraoral finger rests provide stable support for the clinician's hand, allowing precise control with minimal movement. Extraoral fulcrums are essential for effective instrumentation of some aspects of maxillary posterior teeth. Techniques include knuckle rest on the cheek, chin-up thumb, and finger-on-finger fulcrum. Each method offers unique advantages for accessing challenging areas. Instrument activation involves adaptation, angulation, lateral pressure, and strokes. Adaptation refers to how the working end of the instrument is placed against the tooth surface, conforming to its contour. Angulation is the angle between the face of a bladed instrument and the tooth surface. Lateral pressure is the force applied against the tooth, and strokes are the movements used to remove calculus and smooth the root surface. Adaptation is the manner in which the working end of a periodontal instrument is placed against the tooth surface. The cutting edge has three imaginary sections: leading third, middle third, and heel third. Precise adaptation must be maintained to avoid trauma to soft tissues and root surfaces, ensuring maximum effectiveness. Bladed instruments like curettes and sharp-pointed instruments such as explorers require careful adaptation. Angulation refers to the angle between the face of a bladed instrument and the tooth surface. For insertion beneath the gingival margin, the angle should be between 0 and 40 degrees. For calculus removal, angulation should be between 45 and 90 degrees. The exact blade angulation depends on the amount and nature of calculus, the procedure, and tissue condition. Proper angulation ensures effective scaling and root planing. Lateral pressure is the force applied against the tooth surface with the cutting edge of a bladed instrument. The amount of pressure depends on the procedure: firm, moderate, or light. Insufficient lateral pressure may leave rough ledges or burnished calculus, while excessive pressure can damage the root surface. Controlled application of lateral pressure is integral to effective scaling and root planing. There are 4 types of strokes: placement, exploratory, assessment, scaling, and root planing. Placement strokes position the working end apical to calculus or at the base of a pocket. Exploratory strokes assess tooth anatomy and detect calculus. Scaling strokes remove deposits, while root planing strokes remove residual calculus and smooth the root surface. Strokes are initiated using a pull stroke in a coronal direction and may be vertical, oblique, or horizontal. Stroke characteristics vary by type. Assessment strokes are fluid and moderate in length. Scaling strokes are powerful and short, and root planing strokes are lighter and moderate in length. Vertical strokes are used on facial, lingual, and proximal surfaces of anterior teeth and mesial and distal surfaces of posterior teeth. Oblique strokes are for facial and lingual surfaces, while horizontal strokes are for line angles and furcation areas. Scaling is the process of removing plaque and calculus from supragingival and subgingival tooth surfaces. Root planing removes residual embedded calculus and portions of cementum, producing a smooth, hard, clean surface. The primary objective is to restore gingival health by eliminating elements that provoke inflammation. Both procedures require careful technique and adherence to the principles discussed. Supragingival scaling involves holding the sickle with a modified pen grasp and establishing a firm finger rest. The blade is adapted at an angle slightly less than 90 degrees to the surface being scaled. Short, powerful, overlapping strokes are activated coronally in a vertical or oblique direction. The 10 commandments of supragingival hand scaling emphasize direct and indirect vision, proper adaptation, and systematic checking of all surfaces. When adapting the instrument in anterior teeth, the tip should be placed away from soft tissues and mostly pointing downward for upper teeth and upward for lower teeth. The cervical portion should be divided into mesial and distal halves for proper instrumentation. Interproximal scaling is challenging due to calculus attached to proximal surfaces and embrasure areas. Detaching calculus from both labial and lingual surfaces simultaneously is often necessary. In posterior teeth, instrument adaptation requires careful technique. The tip should engage the base of calculus below the undercut for a firm grip before performing the scaling stroke. Scaling is never complete until all surfaces, mesial, distal, buccal, palatal, or lingual, are checked systematically through direct and indirect vision for any remnants of calculus. Subgingival calculus is harder and more tenacious than supragingival calculus, often locked into root irregularities. The curette is preferred for subgingival scaling and root planing due to its design advantages. The curette is held with a modified pen grasp and a stable finger rest. The correct cutting edge is adapted to the tooth with the lower shank parallel to the surface. Controlled, overlapping, short powerful strokes are used, followed by longer, lighter root planing strokes until the root surface is smooth and hard. Evaluation of scaling and root planing is based on tissue response, not just smoothness. Clinical evaluation should not be conducted earlier than 2 weeks post-operatively, as reepithelialization takes 1 to 2 weeks. Positive clinical response may take months, so longer periods of instrumentation or surgery may be required for persistent changes. Ultrasonic instruments use high-frequency vibration to remove supragingival and subgingival calculus. They operate at frequencies of 18,000 to 50,000 cycles per second and include magnetostrictive and piezoelectric units. The instrument tip must be cooled by fluid to prevent overheating. Ultrasonic devices are as effective as hand instruments in removing calculus, plaque, toxins, and reducing pocket depth. Water lavage during ultrasonic instrumentation provides three main benefits: flushing action, cavitation, and acoustic streaming. Flushing removes calculus, blood, bacteria, and plaque from the treatment site. Cavitation involves the collapse of tiny bubbles, releasing shock waves that lyse bacterial cell walls. Acoustic streaming produces pressure within the periodontal pocket, affecting bacteria sensitive to this effect. When selecting ultrasonic and sonic instruments, look for units with adjustable power and varied tip designs. Larger, stronger tips are used for heavy calculus removal, while thin tips are for light deposits and endotoxin removal. Infection control is crucial, as these instruments produce high levels of aerosol contamination. Personal protection equipment and proper patient positioning reduce aerosol production and improve safety. Ultrasonic instruments are used with a light grasp and pressure, which is less fatiguing for the clinician. The tip should be kept moving at all times, with light strokes in a sweeping motion. Overlapping multi-directional strokes are used to remove heavier deposits. Water spray should create a light mist or halo effect, avoiding excess dripping. Proper technique ensures effective treatment and patient comfort. Dental procedures produce aerosols containing microorganisms, blood, saliva, and debris. These aerosols can survive up to 24 hours, posing infection risks. Patients should rinse with antimicrobial solution prior to treatment, and laminar airflow systems are recommended to filter organisms. Personal protection equipment, including gowns, masks, eyewear, and gloves, is essential for both clinician and patient safety. Ultrasonic instruments are contraindicated in patients with cardiac pacemakers, communicable diseases, respiratory issues, compromised gag reflex, porcelain crowns, titanium implants, composite restorations, demineralized enamel, dentinal hypersensitivity, and in children. Vibrations may damage growing tissue, and newly erupted or primary teeth are more susceptible to heat generated by instruments. In summary, mastering periodontal instrumentation requires understanding and applying core principles such as accessibility, visibility, illumination, retraction, instrument condition, stabilization, activation, and maintaining a clean field. Proper technique, patient positioning, and instrument selection are essential for effective scaling and root planing. Ultrasonic instruments offer advanced options but require careful consideration of contraindications and infection control. By following these guidelines, clinicians can ensure optimal patient outcomes and maintain their own health and comfort during procedures.